Thank you. Yeah, so greetings from Cape Town, and I'm going to be sharing the results of a study called Purpose One, a study of twice yearly lenacapavir or daily or FTAF for HIV prevention in cisgender women. So these results were originally shared at the IAS meeting in July this year. So what is the rationale for doing this study? UNAIDS has indicated that in 2022, over 3,000 young women were infected with HIV every week in sub-Saharan Africa. And the decline in HIV incidence was much lower than seen in their male counterparts. PrEP has been available since 2015 and has had a huge global impact with over 6 million people accessing PrEP globally. However, the promise of PrEP hasn't been realized by young women, and uptake, adherence, and persistence remains low. And this is purely due to social, economical, and physical factors that impact them. For them, we need to develop new PrEP options. To this end, we evaluated the safety and the efficacy of twice yearly subcutaneous lenacapavir or daily oral FTAF for HIV prevention. So lenacapavir is a first-in-class, a multi-stage HIV-1 capsid inhibitor. So it acts at multiple points in the HIV life cycle, therefore making it very potent. It also has a long half-life, allowing it to be given as 6-monthly injections. FTAF, the oral study product, is administered in a smaller tablet than FTDF or Truvada. It is more stable and more rapidly absorbed when you compare it to FTDF. FTAF has demonstrated PrEP efficacy and safety in cisgender men and transgender women who have sex with men, but it's not yet licensed for use in women because there were no trials that showed efficacy. So moving on to the study design of the Purpose One study, this is a phase 3 double-blind, active controlled, multi-center randomized trial. So the active control in the study was FTDF. It's a multi-center trial because it was conducted in 28 countries, in 28 sites across 2 countries in sub-Saharan Africa. So 25 sites from South Africa and 3 sites from Uganda. This study had a novel design, and which I'm going to describe now. So the primary aim of the study was to compare lenacapavir, the injectable, and FTAF with background HIV infection to see if they were superior to the background HIV infection. The secondary objective was to compare lenacapavir and FTAF to approved PrEP, that is FTDF. So the study consisted of 3 phases. The first phase was to establish an incident cohort. The second phase was the randomized blinded phase of the study. And the third, not shown here, is the open label extension study, which was conducted after the pre-specified interim analysis was done. So the protocol specified an interim analysis after 50% of participants had completed 52 weeks of follow-up. That is, that they had received 3 lenacapavir injections. So young women between the ages of 16 and 25 were invited to participate or screen in the study if they had not been on PrEP or had had a HIV test in the past 3 months. All of the young women who were screened underwent HIV testing using both a local lab and a central lab HIV antigen and antibody testing in addition to RNA testing. If they were found to have HIV infection, the additional testing for antibody avidity was done to determine whether the infection was recent. If women were positive during the screening process, they were linked to care. Those women who were HIV negative who had a weight greater than 35 kgs, were generally healthy with good kidney function, not pregnant and not breastfeeding, were invited to participate in the study. They were randomized to one of three arms, either to subcutaneous len, FTAF, FTDF, or the corresponding placebo. Participants receiving or randomized to len subcutaneous injection received oral loading doses on day 1 and day 2. Study participants were followed up at week 4, week 8, at week 13, and every 13 weeks thereafter. So moving on to the baseline characteristics. Over a period of 2 years, from August 2021 to August 2023, we screened approximately 8,000 women. And at baseline, 504 were found to be HIV positive and 92 had recent infection. Over 5,300 women were included in the intention to treat analysis. There were 2,000 women in the len group, 2,000 in the FTAF group, and half that number at 1,000 in the FTDF group. The median age of participants was 21 years, so fairly young, and about 2.3% of this number were adolescents in the 16 to 18 year age group. The majority of participants, over 80%, indicated that they had had previous HIV testing, and a small proportion indicated that they had used PrEP previously. As you can see from the STI prevalence at baseline, this was a sexually active cohort. Also important to note that the baseline demographic and clinical characteristics were balanced across all of the 3 arms of the study, in addition to those presenting for the incidence phase of the study. So I mentioned already that the study, the protocol allowed for an interim analysis once participants had reached 50% had reached 52 weeks of study participation. So this milestone was reached in May 2024, and an interim analysis was conducted. The Data Monitoring Committee announced in June that lenacapavir was efficacious and superior to both FTDF and background HIV incidence. And in July of this year, participants stopped participating in the randomized blinded phase of the study. All of them, if they wanted to, were given the option to transition to open label lenacapavir. So now moving on to the results, there were 55 incident infections in total in this 52 weeks of study follow-up, and this was across 5,000 participant years. As you can see on this figure, there were 0 infections in the lenacapavir group and 39 infections in the FTAF group, giving us an HIV incidence of 2.02. There were 16 infections in the FTDF group, giving us an infection rate of 1.69. The background HIV incidence, which we measured at screening, was 2.41. Moving on to the primary analysis, a reminder that the primary analysis was looking at whether lenacapavir was superior to FTAF and to a background HIV incidence. In this figure, the dotted line represents 1, and any value to the left of 1 indicates that the experimental product is superior to background incidence or superior to FTAF and background incidence, and anything to the right shows that it's less efficacious. So here in this figure, we see that lenacapavir was far to the left, indicating 100% efficacy. And FTAF was not different from background HIV incidence, with a confidence interval crossing 1. This figure shows the outcome of the secondary analysis where we wanted to determine if lenacapavir is superior to FTDF. Again, the dotted line represents 1 and any value to the left indicates superiority and anything to the right indicates that the experimental product is not superior to the active control FTDF. Just a note here that FTDF was the active control. We did not use placebo in this study because it would be unethical to do so given that we have a standard of care PrEP option in the form of Truvada and now cabotegravir. So adherence to injection was measured in terms of how many participants or the proportion of participants that presented for their injections on time, that is within 28 weeks, at week 26 and at week 52. And here we see that over 90% of participants presented on time for their lenacapavir injections every 6 months. And this was seen also in the group that not only received active lenacapavir, but also received placebo, an active oral study product. So the bar graph here shows adherence to FTAF and FTDF. Here we see, as indicated by the black shading on the bars, that adherence was generally very poor across both FTAF and FTDF, with the majority of participants having using less than 2 to 3 doses per week. And we also note that the level of poor adherence declined with the time. Moving on to adherence and adherence to FTAF and the likelihood of seroconverting or acquiring HIV infection. So we wanted to determine what was the risk of getting HIV infection for those participants who were adherent to FTAF. So there were 37 HIV infections in the FTAF group, as mentioned already, and this was matched to 159 participants who received FTAF and didn't seroconvert. And so here we see that with higher adherence to FTAF, there was a lower likelihood of participants acquiring HIV infection. So safety and tolerability were important endpoints in this study, and the majority of adverse events experienced were either grade 1 or grade 2. Grade 3 and higher adverse events were rare, and this includes serious adverse events and AEs leading to discontinuation of study product. The commonest AEs experienced were headache, urinary tract infection, and STI. In comparison to the lenacapavir group, participants receiving oral study product experienced more nausea and vomiting. So as this is a study of an injectable, monitoring injection site reactions was an important event. And just to say that lenacapavir, if injected into the subcutaneous space properly, forms a drug depot that may be palpable under the skin, but is usually not visible. So this drug elutes over time and the depot gets smaller and the nodule resolves in size. Important to note that injection site reactions, including nodules, decreased with subsequent doses. So the figure on this slide shows injection site reactions of nodules, pain, and swelling experienced by study participants. We see that most of the adverse events were either grade 1 in red, grade 1 in yellow, and grade 2 in red. So among the 25,000 injections that were administered, 68% of lenacapavir patients experienced any injection site reaction as compared to 34% in placebo recipients. Also to note that 63% of lenacapavir participants experienced nodules as compared to only 16% in the placebo group. Only 4 injection site reactions led to discontinuation of study product. So this study didn't require contraceptive use. It was not an eligibility criteria. Participants were allowed to enroll in the study as long as they were not pregnant or breastfeeding at baseline, but they had the option to stop contraceptive during study participation. So we had 510 pregnancies in the study in 487 participants. There were 193 confirmed pregnancies in the LEN group and 219 in the FTAP group. Also important to note that available pregnancy outcomes were similar to those expected for this population, especially with respect to spontaneous miscarriage or spontaneous abortion. At the time of this analysis, 50% of the pregnancies had an outcome, that is, the mothers had delivered. So to conclude, there were 0 HIV infections in cisgender women receiving twice yearly lenacapavir for HIV prevention, and LEN was superior to both the background HIV incidence and FTDF. Daily oral FTAF and FTDF had poor adherence, and this was very disappointing to see. But it was noted that HIV protection was strongly associated with adherence to FTAF. LEN was generally safe and well tolerated. So this study employed a number of novel features. The firstly is that we didn't use placebo. We used the background HIV incidence as a measure of what the HIV incidence would have been in a placebo group. In addition, participants, pregnant women were allowed to continue with study product of this study. In addition, PK drug levels were collected from the mother during pregnancy, from the infants, and also whilst breastfeeding. So this study is one of the first to give us pregnancy data and data amongst adolescents in terms of efficacy at the time that we get the first positive readout that of the efficacy of lenacapavir. The study, novel study design creates a path forward for future HIV prevention trials. So in terms of the next steps, I've dealt in detail with Purpose 1. There are several other studies in the Purpose portfolio that are currently underway. Purpose 2 showed a 96% reduction in HIV compared to FTDF in cisgender men who have sex with men, transgender women, and transgender men. The study was conducted in several sites in the US, South Africa, Peru, Brazil, Mexico, Argentina, and Thailand. There are smaller studies underway, one of them being in women in the United States, the fourth being in injection drug users also in the US, and then a small study in France and the United Kingdom. So to file for regulatory approval for a new drug, it requires 2 pivotal trials. And so Purpose 1 and Purpose 2 have given us results, very positive results, and these results will be used to file for regulatory approval. Gilead has to make access as much as efficacy is very important. So Gilead has developed a plan to enable access through direct voluntary licensing programs with generic drug manufacturers to to ensure the availability of affordable and good quality drugs to those people who need it most. So it remains for me, on behalf of all the investigators listed on the slide, to thank or express our gratitude to trial participants, their families and communities for participating in this trial. Thank you for your attention. I'm happy to take questions at the end of the session.